Hello, and welcome to Up to Thrive, episode 25, The Skinny on Weight Loss Injectables.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
So today I am again in the coffee nook, and that is because I'm a little bit lazy. I could certainly be recording out in the sunroom today, but everything's set up in the coffee nook, and I've gotten a bit used to it. So I'm just going to hang out in here today. I'm a little bit surprised. I'm actually a little bit ahead of schedule this time, and I'm recording this a fair way in front of the time that it needs to be recorded. So that's pretty cool. I have been very excited about this topic. It's something that I have wanted to do a little bit of a deep dive into for a while now. So pretty exciting. So it's Sunday and we have done our usual Sunday morning stuff. Did the ride with the girls. It was a nice challenging ride as always. And then we hopped in the river and did our swim. I have learned to backstroke. I grew up swimming in rivers and never really had access to a pool, but never actually learned to swim properly. Like I could swim to save my life, but not like proper lap swimming, like the crawl and the backstroke and all those things, the breaststroke and the whatever strokes. And I swim with a few very, very good swimmers. And I only know how to really do the crawl. Something as an adult, I went and got some swimming lessons, and that's one of the things that I learned to do. I'm not good at it. I'm just slow. I'm just a slow swimmer. I just enjoy my time in the river. But I would look at them, and some of them will do the backstroke, and it just looks so relaxing. So, after the bike ride, we hop in, we swim against the flow halfway, and then we turn around, and then it's a nice relaxing stroll kind of back to where we get in at the riverfront. Looking at these girls now for some years and this backstroke, it just looks so relaxing. So I asked if they could, show me how to do it. So I've learned a new stroke, and that has been super fun. It turns out that I think I'm actually reasonably okay at backstroke, probably much better than the other stroke, because I think it makes me kick more. My crawl, sometimes I'm thinking, oh, actually my legs aren't moving. Maybe I should be kicking. So I'm probably like a little prawn. So I've done our Sunday morning exercise. We had some coffee with a new group today. If you are following me on social media, you might have seen Abby Richards. She's one of our young local women who is just a legend. We are very, very much on the same page in terms of building the strongest, healthiest body that you can. Definitely strong, not skinny, and just loving the skin you're in. And so Abby is a local trainer and put a little shout out yesterday to all her girls to go for a walk and have a coffee with her this morning. So after our exercise, we popped in and had a coffee, which was a really nice time. So really enjoyed that this morning. Now let's get into it because we've got some fun stuff to talk about today. If you're anything like me, this is a really interesting topic. Injectable weight loss drugs. So these are the first medications that I have seen in my 20 plus years of practicing that actually work really, really well for most people in terms of significant weight loss. They really are seriously game changers for those people who have struggled with weight issues. They've been around now for a while, and I get pretty regular questions about them. So if you're considering them, if you're on them, or if you're just curious about them, today's episode is going to be packed full of really interesting information. Okay, so let's start with the names of them. The one that most people would have heard of is Ozempic. That is the brand name. The actual drug name is semaglutide. Now, Ozempic was approved in Australia to be used to help treat type 2 diabetes in 2019. It was approved in other countries before that, but in Australia, 2019. Now, the one before Ozempic was called Saxenda, was the brand name, and the drug name was called liraglutide. It's been around for a while, was approved for diabetes and weight loss by the TGA in 2015, but not on the PBS for either. So for those of you who don't know, the PBS is the Pharmaceutical Benefits Scheme in Australia. So the government helps subsidize medications for Australians. And so when something's on the PBS, that means that you get it at a discount rate. When it's private, it's generally more expensive. Saxenda's a daily injection, it's quite expensive. In fact, about $100 more than the other ones that are weekly injections. So I didn't have a lot of success with Saxenda in my time. It's been around a lot longer, but in my experience, the cost was prohibitive. So it's less expensive now than it was, but at one point it was, I think it was, $400 something a month. And I wasn't getting a lot of success on it. So I didn't have anyone really using that one long term. I did do a quick literature search and I found that there was one randomized clinical trial that compared semaglutide, which is one of the ones we're going to talk about today, with liraglutide. They had 338 participants and the study ran over 68 weeks. And what they found was that the semaglutide group lost 15.8% of their body weight, where the liraglutide group lost 6.4%. So that pretty much backs up what I have seen in my practice. Now, the two new ones that you will likely have heard of, the first is Wegovy, which is semaglutide. In fact, it's the exact same as Ozempic, even made by the same manufacturer. The only differences are that Ozempic is PBS listed for diabetes, and though Wegovy can be used for diabetes because it's the exact same medication, it's not on the PBS, but it is approved by the TGA and targeted for weight management patients under a private script, which, funnily enough, is about $100 more than the old private Ozempic scripts. Ozempic was never TGA approved for weight management, so it had been given on a private script and used as what we call off-label, so not being used for what it was approved for. Another difference between Wegovy and Ozempic is that Wegovy comes in a different delivery device, and it can be prescribed in doses that are double what the Ozempic is available in. Now, the issue that brought about the creation of Wegovy was that they were running into medication shortages with Ozempic, and that meant that people who were using it as part of their diabetes management weren't able to get it. And we, as prescribing doctors, were at one point told not to be prescribing it for weight management, to only be giving it to our diabetic patients. So then the manufacturer decided to make two labels. So that meant that there would be stock of Ozempic set aside for diabetic patients and then a separate stock for weight management patients. Now, funnily enough, we are told to expect shortages of Ozempic throughout the remainder of the year. So I think that maybe the cost of Wegovy is what keeps it from being in a shortage. I'm not sure. Anyway, the newest one on the scene, though, is called Mounjaro. The drug name is tirzepatide. It was TGA approved in 2023 for diabetes, and then in 2024, it was TGA approved for weight management. It is not on the PBS for either. All of these drugs, liraglutide, semaglutide, and tirzepatide, so Saxenda, Wegovy, Ozempic, and so Wegovy and Ozempic, same thing, and tirzepatide, which is Mounjaro, they are classed as what we call glucagon-like peptide-1 receptor agonists, or GLP-1RAs, or commonly we just refer to them as GLP-1s for short. Tirzepatide does, though, have what we call a dual action, so it has two actions. It's not only a GLP-1 receptor agonist, but also a glucose-dependent insulinotropic polypeptide, or GIP for short. So let's break it down a little bit. I'm going to make it really simple. I'm not going to nerd out too much, but I think the mechanism is super interesting, so I'll try not to bore you too much. When something is an agonist, it means that it can fit onto a receptor and cause a physiological response. So there's a GLP-1 receptor, and the GLP-1 receptor agonist fits onto that receptor, and it causes the same response as our own body's GLP-1. So let's talk about what our own body's GLP-1 does. When we eat, we secrete this hormone, GLP-1, mostly from our ileum, which is the last part of our small intestine. And then there's some produced in the pancreas and also in our brainstem. Now, this hormone binds to GLP-1 receptors in the gut, and it slows down how quickly food leaves our stomach. In the pancreas, it helps to release insulin to clean up any excess glucose we have in our bloodstream, and also to stop something called glucagon from being released. So it's glucagon's job to get more glucose into the bloodstream when we're getting low. So essentially, it helps us manage our blood sugar levels because, as we know, too much sugar in our blood is toxic. It's what we call diabetes, right? So GLP-1 also works on the appetite centers of the brain, helping us know when we're satisfied, so we know when to stop eating. So that's our natural GLP-1 that is released in our bodies when we eat. Our natural GLP-1 doesn't live very long. It lives for like 1 to 2 minutes. Now, if we compare that to what happens when we use the GLP-1 receptor agonists, first, they have a much longer half-life. So Ozempic, same as Wegovy, as we talked about, semaglutide, they last for a week, which is why the injections only need to be given once a week. We have an injection and we have all of this GLP-1 RA floating around, constantly slowing down how quickly food is leaving our stomach. So it causes a feeling of fullness so you don't eat as much. It's also working on those appetite centers in the brain so you don't feel hungry as much. Although this is a bit variable, some people feel hungrier than others. But one thing I have heard a lot of with this medication, for lots of people, it quiets food noise, that constant thinking about food. And then there's the blood sugar management too, but then when someone isn't diabetic, they don't have a bunch of extra glucose to sort out. So these medications only really cause release of insulin in response to how much glucose it needs to sort out. So the risk of having a hypo or a low blood sugar attack is pretty low in non-diabetics. It's a risk to consider for diabetics who are on other diabetic medications. So for people who are not diabetic, not on diabetic medications, it's not something generally we need to worry about. Now, these GLP-1 RAs also slow down how quickly the GLP-1s our bodies make are broken down, so they can hang around a bit longer too. So that is how these drugs work. Now, as I said at the beginning of this episode, these medications are the most powerful treatment option besides surgery that I have seen for weight management. And we also know that they can be used to treat diabetes, but apparently these things are not all that they're good for. There is some data that suggests that they may also lower the risks of dementia, mental health issues, heart disease, and lung issues. There's evidence that they can help with inflammation, blood lipids, and blood pressure, which are super important to help prevent heart attacks and strokes. In fact, the TGA has approved Wegovy for a relatively new indication, and that is to reduce the risk of major adverse cardiovascular events. So, death or a non-fatal heart attack or stroke in people who already have heart disease, who are overweight or obese, but they don't have diabetes. This approval came after the data was released from something called the SELECT trial. It was an international study that had more than 17,000 participants in 41 countries, and it found that Wegovy reduced cardiovascular events by 20% in this population. So people who had known heart disease and who were overweight or obese, but they didn't have diabetes. It still isn't on the PBS though for this indication or any other indication. So even for these patients, it's still going to cost somewhere around $250 a month. I'll talk a bit more about the price in a minute. But let's turn our focus a bit to Mounjaro or tirzepatide. Tirzepatide, sold as Mounjaro, has a dual action. And so it does all those things we talked about before as the GLP-1 RA, but it also has a second mechanism of action as a glucose-dependent insulinotropic polypeptide or GIP. So this GIP is another what we call incretin, as is GLP-1. So an incretin is a hormone that our bodies release when we eat that stimulates insulin release, and it plays a role in regulating our blood glucose levels and our appetite. So theoretically, you get a little bit more bang for your buck with this dual action. We'll talk a bit more about that later, whether this is really true. Now, which one do studies show is better? I'll say that tirzepatide does have one other really interesting action that may be something worth considering, especially if you're a midlife woman, and that is because the effect of menopause, and in particular the lack of estrogen, has on our bones. So after menopause, our risk of osteoporosis or thin, fragile bones increase. Remember that 1 in 3 of us women after the age of 65 is going to just have a simple fall and fracture a hip compared to less than 1 in 10 men. Never going to get tired of telling that statistic. There are lots of other things that can put us at increased risk of osteoporosis too. Things like diabetes and obesity. So great, these medications can treat both of these. But you know what else can impact our bones? rapid or significant weight loss like you get with these medications. Now, we can counteract that by ensuring that we're doing our resistance exercise. So really working those muscles and getting our protein so we can protect our muscle mass, and protecting these muscles is going to help protect our bones. Now, I did find one randomized clinical trial that looked at 195 obese adults over a 1-year period of diet-induced weight loss. So they split them into 4 groups. They had one group who just did exercise, one group that just took a GLP-1 RA. It was liraglutide, that daily injection that I talked about. And then there was one group who did both exercise and liraglutide, and then a group who took a placebo. Everyone lost bone density. The liraglutide alone group lost the most bone density, and placebo lost the least, but they also lost the least amount of weight. The exercise alone group did the best in terms of bone density, but they still did lose some. The combination group, so the liraglutide plus exercise, was somewhere between the medication alone and the exercise alone group. So it suggests that exercise can help us somewhat preserve our bone density when we're taking these medications. But remember, liraglutide, it is a GLP-1 RA, but the once daily injection. So it's a little different than Wegovy or Ozempic, same thing, which is what we've been focusing on today. So whether that makes a difference in terms of bone loss, I don't know. And honestly, the jury's still out in terms of bone loss. I'm not sure that we have enough information yet to confidently say. But the literature suggests in general that the GLP-1s probably have a neutral effect on bone mass, where tirzepatide might be a different story. Both our natural GLP-1s and our GIP, remember, these are the 2 things in tirzepatide and 2 things that our body naturally makes as well, that our natural hormones have very similar mechanisms on our bones. But where Wegovy indirectly affects our bones through that GLP-1 pathway, our bones have receptors for GIP directly. And we know that when the GIP receptor is activated, it inhibits the breakdown of bone. So our bones are constantly being remodeled, so being broken down and built back up. The GIP activation inhibits the breakdown of the bone and at the same time promotes bone formation. So we don't yet know for sure, but there are some studies suggesting that tirzepatide having these dual actions might be a bit more beneficial for our bones. But the jury's still out, like heaps of things, and we still need some more research. All right, so let's talk about adverse effects. What can you expect from these medications? Well, the side effect profile is pretty similar for both of them. Knowing that a big part of how they work is on the gut and the pancreas, it makes sense that the most common side effects are going to be gut-related, like heartburn, reflux, nausea, vomiting, diarrhea, and constipation. And there's also been reports of headaches, fatigue, and hair loss. The side effects are pretty common, but they do seem to be mild to moderate at most, and they seem to improve for most people with each subsequent week that they're on the medication. Serious adverse events that would keep people from taking the medication, so make them stop, those are pretty rare, but there are a few things to be aware of, and maybe a few things that you might hear about along the way and frighten you unless you know a little bit more about them. So we're going to talk about a few of those now. There may be an association with pancreatitis. So pancreatitis is inflammation of the pancreas. It's pretty horrible. I've treated lots of patients with pancreatitis. It's very painful. You can't eat for a while, and it needs to be managed in hospital most of the time. Now, if you've ever had pancreatitis, you know what I'm talking about. And though the product information says caution should be exercised in patients with a history of pancreatitis, I'd probably be a bit reluctant to prescribe that myself for people who've had pancreatitis in the past. And if you've had pancreatitis in the past, you'd probably be a bit reluctant to take it. You may have heard something about a risk of blindness, taking semaglutide in particular. What that's referring to is an increased risk of worsening of something called diabetic retinopathy. So diabetic retinopathy refers to issues with the blood vessels of the eyes caused by diabetes, and it can lead to blindness. It's one of the reasons that we get all of our diabetic patients to have regular eye checks. It appears that with diabetics who already have this condition, that there is an increased risk of it worsening. So something to consider if you have diabetic retinopathy already. Now, a paralyzed stomach. I've heard this floating around a bit. So something called gastroparesis. That's when there is a significant delay in the emptying of the stomach. As we talked about, there is slowing of the emptying of the stomach with these medications because that is one of the ways that these medications work. But the symptoms are only mild. Gastroparesis, however, those symptoms are more severe and they would include upper abdominal pain. There were some studies in rodents where semaglutide caused thyroid tumors, including thyroid cancer. So we don't really know if it's going to cause thyroid tumors or thyroid cancer in people, but the recommendation by the manufacturer is that you don't use it if you or if any of your family have ever had something called medullary thyroid carcinoma, or if you have an endocrine system condition called multiple endocrine neoplasia syndrome type 2. So for short, that's MEN2. Now, human studies have not consistently confirmed this risk. It appears that the absolute risk is small, so worth knowing about in case you hear it and no one had told you. In terms of pregnancy, these medications are not recommended during pregnancy. Some animal studies have suggested that there might be risks to the fetus, including fetal abnormalities, and it's recommended that women take contraception while they're on these medications to avoid pregnancy. I know that the Royal Australian and New Zealand College of Obstetrics and Gynecologists recommends that not only do women take contraception while they're on these medications, but also to come off of it for at least 2 months before planning a pregnancy. And if they're on it for diabetes, then to consider other options. Like a lot of things in terms of pregnancy, we can't do human studies on pregnant women and babies, so most of this information does come from animal studies. Okay, now, the criteria that we are given to guide us in prescribing Wegovy. Ozempic has a different set of prescribing rules, as I mentioned earlier, so that's for the diabetics. Wegovy is for either the obese patients or overweight patients who have heart disease or for weight management. The guidance is that it should be prescribed along with a reduced calorie diet and increased physical activity. And then there's some BMI criteria. So remember, BMI is calculated by dividing your weight in kilos by your height in meters squared. So to be prescribed Wegovy, you should have an initial BMI of over 30, so that's considered obese, or over 27, which is considered overweight, if they also have at least one weight-related medical condition. And that would be things like high blood pressure, high cholesterol, sleep apnea, heart disease, they're pre-diabetic, or they've got type 2 diabetes. The type 2 diabetics can have Ozempic, but have to meet other criteria. You can be diabetic and not on medication, so diet-controlled diabetes, and these patients wouldn't qualify for PBS subsidy for Ozempic. But they can certainly take Wegovy just at a higher price. Wegovy's manufacturer, Novo Nordisk, has tried several times to get the medication under the PBS for severe obesity, but it's been rejected every time. So for Mounjaro, it's the same criteria as Wegovy, and Mounjaro is not on the PBS for anything. And this is probably a good time to talk about the price. So how much are these medications going to set you back? I just saw some discussion on social media last night about the cost in the States. They seem to be really being gouged because the Canadians were making some comments, and I know that our costs are a lot less as well. So for Wegovy, it's about $250 a month for the first 3 doses. So you start at the lowest dose, and generally, after a month, you increase that to the next dose. And you keep increasing it, titrate to effect. So you keep increasing it to try to get the desired effect. So you have the first 3 doses, then the price goes up to about $370, and then about $450 for the highest dose, as I said, at least here in Australia. So there are 5 doses that you can work through in Wegovy. Mounjaro starts at around $280 a month, and then it goes up roughly $100 to $150 with each subsequent dose. There are 6 doses of Mounjaro and 5 for Wegovy. So which one works better? Well, It appears that weight loss over a year for both of them ranges somewhere between 10 and 20% of their total body weight. But tirzepatide does look like it's a little bit better. The general consensus from colleagues who use both of these drugs is that tirzepatide does seem to work a bit better, and this is backed up by some recent data that was released late last year. In December, there were some preliminary results released from a randomized control trial called the SURMOUNT-5 clinical trial. There were 2 groups compared, both non-diabetic populations. There was Mounjaro compared against Wegovy over a 72-week period. Both groups lost significant amounts of weight, but the tirzepatide group or the Mounjaro group lost an average of 20.2% of their body weight, so that was about 22.8 kilos. And the Wegovy or semaglutide group lost an average of 13.7%, which is about 15 kilo loss. We do have to keep in mind that this trial was sponsored by Eli Lilly, which is the pharmaceutical company that makes Mounjaro or tirzepatide. So we have to be a little bit cautious about some potential bias, and also because these results are preliminary, so they haven't been peer-reviewed and they haven't been published yet, which is meant to be happening sometime this year. So we'll know how that goes, but it does appear that the study backs up what we're seeing in clinical practice, and that is that tirzepatide does maybe have a slight edge. So let's say that you're using one of these medications and it's working a treat. How long are you meant to stay on it? This can really spark some debate. In fact, there's some pretty strong opinions, both professionally and just in society in general. But my college, the Royal Australian College of General Practitioners, advises that if it's working and it's well tolerated, then it should be continued just the same way as blood pressure or diabetic medications are continued, even after the blood pressure or the blood sugar is controlled. This is because obesity is considered a chronic disease that requires sustained treatment. So generally, it's recommended that if the patient has achieved what's considered a significant early weight loss, so more than 5% weight loss in the first 3 months of use, then they should continue the medication long term unless there's some reason to stop it. So they're not tolerating, they can't afford it, they're having a baby, some reason. What we know is that when we do stop these medications, there's often significant weight regain, somewhere around a half to 2/3 of the weight that was lost within a year of stopping the medication. So that's pretty typical of what happens when people stop a restriction diet as well. Now, I just want to mention one other thing. When people go on a diet, they tend to lose muscle and fat. Typically, this is around 25% muscle to about 75% fat loss. There's some suggestion that these medications can cause a bit more muscle mass loss than the average diet. I'm a little confused though. There's 2 sources that I trust very much, and they're saying 2 different things. One is saying, yes, there's more muscle loss, and the other one saying, no, there's not. And then the literature I found did suggest that there was a bit more muscle mass lost. So I'm going to err on the side of caution and go with that. However, it really doesn't change the way that I practice. In my practice, these medications require an in-depth discussion with the patient about how they work, and in particular, the risk to muscle mass. As you've heard me talk about probably ad nauseum, sorry, not sorry, we absolutely have to preserve our muscle mass as we age for optimal health, to help us avoid all kinds of significant chronic diseases that menopause is already going to put us at risk of. So for my patients, I counsel them on getting enough protein to help protect their muscle, and at the same time doing 2 to 3 days at least of resistance training. I'm also very much on the page of let's see if we can set ourselves up for long-term success. And so if we do decide to come off of the medication, we have built some strong protective habits to help maintain that weight loss. I do this both with and without these medications. So if people want to make body composition changes on their own without medication, my approach is exactly the same. You would have heard me talk about this before if you've been listening. Protein is the very first thing that I target because I know that it's evidence-based for weight loss. Fiber is the next one, and I look at the energy budget. I teach people how to manage an energy budget. Something I myself learned was kind of not really forced to learn. I chose to learn around this midlife period when I put on weight. and then had to look at my pattern of yo-yo dieting over many years with this, kind of subtle gain, loss every year, and then hit this midlife period. My body just wasn't doing what it had always done. And I had to take a step back and admit that my nutrition really needed some dialing in. I just needed to tweak it a little bit. And that has just worked a treat. And it can for you too. I just want to finish by saying these medications don't work for everyone. I do have a few patients, they just don't seem to be getting the same benefits as most other people do. And it's the same thing with the side effects, that some people just don't seem to really be affected at all, much at all, and others a bit more. So I hope that that's been as interesting to you as it has been for me. I really, really enjoyed looking into all the literature. It's kind of a newer area in weight management medicine. It's an area that I have always really, really enjoyed working in. So I hope that you found this interesting or helpful. And if you can think of someone who might get something out of it, please, as I always say, pass it along. And if you haven't yet rated the podcast, can you please do that today? Maybe give me a little bit of a rating. I would love a review so I know exactly what you're thinking, how I'm going, what you'd like to see more of. So if you can leave a written review, that'd be awesome too. I hope you have a great week, everyone. And until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts for medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.